Hello everyone, this is Nicole here. I am a neuroscientist and research project manager in the Department of Psychiatry and Mental Health at the University of Cape Town. Today my talk is going to be about HIV-Associated Neurocognitive disorders in adolescents, how to assess it, the signs and symptoms and the impact thereof. And before I jump into it, I just want to say thank you to Dr. Hita Gousa and Dr. Ruben Robbins for inviting me to contribute to this brain lectures seminar series. I'm looking forward to sharing this information I've learned over the past couple of years with you all, and I'm looking forward especially to the Q&A. So yes, let me jump right in. So when we think about the adolescent brain, this is maybe what we think we're going to find. Look at the birds and bees lobe. And then my favorite here is the love or disdain for parents lobe. They've got a rebellion center, they want to fit in, they have a sense of indestructibility. And all these things that we think goes on in the inner workings of a brain of an adolescent. But in actual fact, neuroscientifically speaking, this is what's really happening in the adolescent brain. It is still very much under construction. It is constantly changing, gaining information, gaining new cognitive abilities. And so it's a very different picture from that we see in adults. So looking at the difference in neuropsych testing in adults versus adolescents. When you are doing neuropsych testing with adolescents, you need to remember that the brain is still developing. Whereas in adults, you are testing a function of a person whose brain is already fully developed. So when testing with adolescents, you always need to ensure that you use age-appropriate measures, and sometimes those measures are different for different age ranges, even on the same test measure. Whereas for adults, most of the time, the age-appropriate measures are the same for all the different age ranges for adults. In adolescents, there are also vastly different levels of performance, and so this changes the way in which you need to approach the testing session. In adolescents, their mood also really affects the testing session, how the testing gets done, how smooth the process will be, and it will also affect the quality of the session and the quality of the performance you are able to get out of the adolescent if you are conducting the neuropsych testing. For adults, they are much older, more matured, and able to regulate their mood more consistently. So the process of testing in adolescents requires you to establish a really strong rapport right from the start of the session. It is a very good idea to, right at the start of a session with an adolescent, establish a relationship, a working relationship with them. This rapport will really help you through the entire session with the adolescent. If you are able to connect with them on a person-to-person basis, you are going to get a much better output from the adolescent. You are going to have a person or an adolescent in front of you who will be more invested in the session if you take the time to establish a good working rapport with them. Testing in adolescents also requires lots of patience. You might have to repeat instructions more than once or twice. And also they might just go through the session at different paces. A 13-year-old might need a slower pace than what a 15-year-old requires. But it also depends on their level of proficiency. And so the session is really guided by how the participant or how the adolescent is able to engage. And so as the neuropsych test administrator, you need lots of patience, not only with yourself, but with the adolescent as well. To conduct neuropsych testing in adolescents also requires a high level of observation on the part of the neuropsych test administrator. And the administrator needs to be very observant, very in tune, and very aware of how the adolescent is doing during the session. So you need to look for signs that tell you, is the adolescent engaged in the session? How is their overall mood? Are they feeling fatigued? And so you need to be aware of these kinds of moods and changes in the adolescent, as this might fluctuate quite a bit because they are, still young and still getting to that level of maturity where they are able to sit down and concentrate for an extended period of time and give a certain level of output for that extended period of time. And so the session will be guided by how often the participant needs to stop for a break. You might find that some participants need more breaks than others. Some just want to continue on and are feeling really engaged with the process and would like to just continue and get through the tests, whereas others require more input from you and more encouragement from you to get invested in the session and to move along with the process. Neuropsych testing with adolescents also requires good organization. If the test administrator is organized, the tests run in an orderly and systematic fashion, the test administrator knows what's happening when, what's coming next, and is aware of little breaks between tests and how to utilize those breaks between tests to connect with the adolescent. Those test administrators often get better results out of the adolescents. When the session is very organized and running smoothly, it also leaves you with more time for those high-leveled observations, because you won't be having to put any effort into organizing the session if you have prepared everything beforehand. The other major soft skill I really feel strongly about when doing neuropsych testing with adolescents is that we show them lots of kindness throughout the session and give them lots of positive feedback throughout the testing session. Even if they are not doing well, you're still wanting to give them lots of positive feedback to keep them encouraged, to not let them become demotivated throughout the process, and to also keep them engaged with the session, because if they are not properly engaged with you, with the process of the neuropsych testing, you're not going to get the best performance out of them. And when we are conducting these batteries of neuropsych testing in adolescents, what we really want on the document is the adolescent's best performance, because more often than not we'll be using that document to make a judgment or to make a clinical informed decision as to how they are performing, as to whether they have a neurocognitive disorder or not. And so every testing session should be geared towards giving that adolescent the optimal chance and the optimal environment to provide their best performance. As part of the CTAC, which is the Cape Town Child and Adolescent Antiretroviral Cohort, we did a large battery of neuropsychological tests. which is considered the gold standard of neuropsych testing. The entire neuropsychological test battery took about 5 to 6 hours per adolescent participant. And so you can imagine that that is quite a bit of information. And so how do we use all those individual tests to make informed decisions about how the adolescents are performing? What we did with all those tests is we tried to combine groups of tests which test the same neurocognitive construct, and we grouped them together, ran Cronbach's alpha test to check for reliability and connectedness between the items, and then we created composite cognitive domain scores. For example, in the general intellectual functioning cognitive domain, we included the WASI vocab, similarities, block design, and matrix reasoning subtests of the WASI. This column here for the intra-test information shows us for each subtest how many items there are and the score range for the total test or subtest. This is the Cronbach's alpha value, and we aimed for each of these cognitive domains to have a Cronbach's alpha score of 0.7 or more. So we repeated this process for 10 different cognitive domains. For the attention domain, we used the color trails 1 and 2. For the working memory composite cognitive domain score, we used digit span, color trails 1 and 2, and the different subsets of the NEPSI test. For verbal memory, we used the Hopkins verbal learning test. Visual memory, we used the Ray-Ostrich complex figure. Visual spatial memory, or visual spatial ability rather, we use the Ray complex figure but the copy subtest only. Language, we use the Boston naming test. Motor coordination was the NEPSI finger tapping test for the dominant and non-dominant hand. For processing speed, we use the WISC, symbol search and coding, and the different subsets of the NEPSI inhibition test. For executive function, we included the NEPSI naming, inhibition and switching. Those are the different 3 subtests of the NEPSI inhibition executive function tasks. We used the matrix reasoning and similarities of the WASI, color trails 2, and the verbal fluency test. So in setting up these composite cognitive domain scores, it enables us to do 2 things. It enables us to give an overall comment on how the participant is performing in different cognitive domains, as opposed to an overall score. The benefits of being able to describe a participant's abilities or performance with regards to domains compared to a global overall score is that we are able to see domains in which they are functioning poorly and also domains in which they are functioning well. So the composite cognitive domains method really gives us the ability to comment on the participant's strengths and weaknesses, whereas a global score just kind of gives a general score, one single general score, which doesn't really tell us that much about the participant's performance. The second thing that having composite cognitive domain scores allows us to do is to count how many domains the participant has impairment in, and then use that as part of the criteria for the Youth Neurocognitive Disorders Classification System. For this lecture series, I'm not going to go into detail about the classification system. I will leave a paper for the classification system in a resources folder, which you can access at any time after this talk. But in brief, what that classification system allows us to do is to classify participants according to a major neurocognitive disorder, a minor neurocognitive disorder, or no neurocognitive disorder. So these composite cognitive domain scores allows us to do those two things. It allows us to determine the participant's strengths and weaknesses, and it also allows us to apply the criteria, the diagnostic criteria, to determine whether a participant is a major, minor, or no neurocognitive disorder. As I mentioned in the earlier slide, the gold standard neuropsychological test battery takes quite a long time to administer. It can take anywhere between 4 to 6 hours per participant. A lengthy battery like this is not feasible in a low resource setting like South Africa. So for this reason, a valid quick screening tool is needed. What we did was we took an already existing tool, the International HIV Dementia Scale, and we validated this against the gold standard battery to create a slightly modified version of the IHDS, which is valid for screening in children and adolescents. So this slightly modified version we refer to as the Youth International HIV Dementia Scale, or y-IHDS. The y-IHDS takes about 3 to 5 minutes to administer, and the benefits of having a quick screening tool is that we are able to roll this out more widely to more participants. And what the screening tool does, it informs us whether a participant is at risk for a neurocognitive disorder or not. The screening tool does not diagnose. It cannot diagnose whether a participant has a neurocognitive disorder or not, but it will tell us with reasonable accuracy which participants are at risk for having a neurocognitive disorder and which participants do not have a risk for a neurocognitive disorder. Which means if we are able to roll out the screening more widely, we would be able to more accurately refer the participants who need the gold standard battery testing more accurately and more feasibly than not having the screening tool or just referring all participants. So I'm going to play the short video so you can see how quick the y-IHDS.
Today we are going to be doing a quick activity which will give us really useful information. Some parts of the task will be easy. Other parts will be difficult. You are not expected to get everything right. Just try to do the best you can. I'm going to time some parts of the test and write the answers down. If you don't understand something, please ask me to explain it again. Do you have any questions?
No questions.
Okay. Which hand do you use most of the time? Okay. All these tasks, we are going to use your opposite hand.
So,
Okay, let's get started. Have you ever repeated a grade at school?
no,
I am going to read 4 words to you. Dog, hat, bean, Red. Please repeat the words back to me.
Dog hat been red.
Good. I'm going to ask you to repeat these words again later. Please, can you do the same with your first two fingers of your non-dominant hand like this? You need to do it as widely and as quickly as possible.
Okay.
Good. Now I'm going to time you. When I say go, tap your first two fingers as widely and as quickly as possible. Ready?
Yes.
Go. Thank you. Please, can you do the same with your non-dominant hand like this? You need to do it as quickly as possible. Good. Now I'm going to time you. When I say go, do the hand movement as quickly as possible. Ready?
Yes.
Go. Thank you. Please, can you tell me the 4 words I gave you at the start of this task?
Dog hat been red.
Thank you.
Is. And that's it. So this took a little over 3 minutes to administer, and it shows you just how quick a screening tool can be as opposed to the long, lengthy battery. So when working with adolescents and when thinking about the signs and symptoms of HIV-associated neurocognitive disorders in adolescents, it's important to remember that where signs are considered, it's not always visible or obvious upon face value. Just by looking at the participant or by a short, brief interaction with the participant, you would not be able to determine who has cognitive impairment and who doesn't. When it comes to neurocognitive disorders, you need to have time to assess which participants have the impairment or not. So like I mentioned, a quick screening tool helps us to assess for the risk of impairment as to whether the participant has an impairment or not, a diagnostic impairment or not. We still need the gold standard testing battery. And so even before you do the gold standard battery, just by inquiring from the participant about their daily life, doing a detailed history, you can find out if the participant is struggling or failing at school. As part of our studies and as part of the validation process for the y-IHDS, we discovered that participants who had previously failed a grade at school were at an increased risk for cognitive impairment. So finding out from the participant or from their parents if they have previously failed a grade at school is a very good indicator as to whether they are struggling cognitively or not. You can also inquire about language difficulties, memory problems, possibly trouble paying attention in school or at home or within certain activities. You can find out from participants if they have trouble planning and organizing tasks and organizing themselves. They may also display behavioral problems, which in most cases are reported by their parents. And it's important to remember that the signs associated with HIV-associated neurocognitive disorders is often under-recognized in our busy clinical settings. Where symptoms are concerned, these are what the participant may report to you. And when the participant or the adolescent is reporting these symptoms to you, it's important to remember that because they are still young, because they are still maturing and coming into their own, getting to know themselves, they may have poor insight and may therefore not accurately report their symptoms. From previous experience, what most adolescents are able to report to us as far as difficulties or symptoms with cognitive difficulties is they may report memory problems. They may also report an inability to concentrate at school. So when we talk about the signs and symptoms of HIV-associated neurocognitive disorders in adolescents, it really is a combination of doing a good history with the participant themselves, taking some history from the parents or from teachers, and also doing thorough neuropsychological testing. Neurocognitive disorders is not something people wear on their sleeves. It's not, for example, like a participant or a patient going to a doctor who has the flu. They might be coughing, they might have a runny nose, they might have a temperature. And these are the signs, the physical signs the doctor would look at when making their diagnosis. And then the patient will also report symptoms like, I have a pain in my chest. So neurocognitive signs and symptoms are very different to those of physical medical problems, because you need to dig deeper to get to what those signs and symptoms are. So what is the impact on the adolescent if they are diagnosed with an HIV-associated neurocognitive disorder? In most cases, participants would struggle with poor performance at school, and more often than not, they would have failed a grade at school. They often struggle to perform daily tasks such as caring for themselves, remembering to do things, or planning a daily activity. Parents also report behavioral difficulties at home. They may also be displaying behavioral difficulties at school. With regards to behavioral difficulties, these could be as a result of the brain dysfunction and the cognitive impairment, but it may also be as a result of other factors, emotional, psychosocial, or other. Having cognitive impairment, there is also the risk of the participant or patient having poor ARV adherence, because they have poor memory or poor executive function, being able to plan and organize things, poor attention to detail. Participants may not be taking their ARVs as adequately or doing it in the way that their doctors have prescribed because of their cognitive difficulties. There's also long-term impacts on adolescents, and it often impacts their future prospects. It could impact their ability to retain a job or within a job to meet the basic job performance requirements. It also has an impact on their clinical functional impairment. And these functional impairment tests are quite lengthy and difficult to do, and actually requires a proper OT assessment. But clinically speaking, when we try to create a clinical picture of how the person is performing in their current situation, more often than not, we find that cognitive impairment is also associated with overall functional impairment. So what do we do? This slide was almost going to be very long, but I decided to focus only on the cognitive testing issue with regards to cognitive disorders, because there are a whole list, there's a whole range of things we should be doing to assist these adolescents. But insofar as cognitive testing is concerned, what we do need is to improve our screening measures. And the way we can do this is by adding cognitive screening questions to the y-IHDS. Adding cognitive screening questions to a screening tool increases the sensitivity and specificity of a tool, and I've included the reference here to a study where they did just that. They included cognitive screening questions and demonstrated how adding these questions to an existing tool increased the sensitivity and specificity of the tool. With improving the screening measures, we then also need to increase our efforts to screen for these neurocognitive disorders in adolescents. The y-IHDS is a tool which can be administered by teachers, doctors, healthcare workers, social workers. It can be easily administered. It doesn't require equipment. It requires only a pencil and a paper. And we need to increase the rate at which we screen participants for neurocognitive disorders so that we have a better understanding of how many adolescents are at risk, and then we, with the knowledge of how many are at risk for neurocognitive disorders, put in place measures to then screen or test these participants with the gold standard battery and then get them the interventions that they need. I've created a Google Drive folder with a few resources that go along with this talk. I've included some journal articles for extra reading, and I've also included the y-IHDS tool itself, plus the videos, the English video and isiXhosa video demonstration on the tool. If there are any other resources with regards to child and adolescent neuropsych testing which you would like, you can pop me an email. My email address is here at the bottom. If I have access to the resource you are looking for, I'm more than happy to upload it to the Google Drive folder. And with that, I would just like to say thank you for listening. I'm looking forward to the Q&A session. And I hope everybody is keeping well, keeping safe in this time of the coronavirus pandemic. We are all in this together. And as South Africans, we have a saying that we are stronger together. So while we practice our physical distancing, we are still united in our efforts to combat this pandemic. So remain hopeful. We are stronger together. Thank you.